introduction, Dr. Sethi, and then I'll sort of forfeit my screen and turn it over to you. And then, as you mentioned, we'll have a little bit of time at the end to ask questions. So everybody, if you could just hold your questions to the end. So welcome to the West Coast Fellows Conference. This is our 9th iteration. Obviously, we continue to grow and are really grateful to everyone for their participation. These discussions will all be posted on our website, and they're easy to find links. So any questions, just reach out to us. Before I turn it over to our speaker today, I just wanted to put a quick plug in for a grant opportunity for any fellows or young faculty through the SDSF, which is our research and fellowship training organization. It's a pretty generous opportunity and not too many strings attached. So we're looking forward to applications. You can use the link there at the bottom to get more information, or just reach out to any of us to have the application emailed to you. So without further ado, then I'm going to turn the monitor over to our speaker, Dr. Sethi from Virginia Mason. I don't know if Greg is logged on, I'd give him the opportunity to do the introduction. That may be him there, M connecting at the bottom. Greg, are you on? He can sometimes be running a minute or two behind, but we're very honored to have Dr. Sethi with us. I first came to know him and his work largely through some of the interdisciplinary protocols he set up to tackle deformity. And it's something that we've tried to emulate here in San Diego and learned a lot from. So thank you for that. Today, we're going to talk about robotics and navigation, which is something that as trainees, you're going to have more and more access to, and certainly it's going to become a bigger part of your practice. It's something that's very near and dear to my heart. And so I look forward to hearing from you, Dr. Sethi, and thank you so much for being here.
Thank you. So I'm going to try to share my screen here first. Honey, you're able to see that okay?
Yeah, that's coming in loud and clear.
Okay, all right. I'll going to spend just a quick 20 minutes here, and then I'm going to leave a couple of minutes for questions, because I think that's really, really important as we go forward. Here are my disclosures. So as we talk about value in healthcare, we really have to think about this quotient, which has been well discussed now in many forums about the outcomes and the costs of delivering these. And we know that we're in a difficult position in spinal surgery around the world. And this map here, if you want to call it that, stopped in 2010, but it really continues to spiral out of control vis-a-vis this cost conundrum. Same time, I spent a large portion of my career thinking about safety and value, and how can we take our work farther with the situation of this case. Is this case actually acceptable? We talk about this in a state-of-the-art review that we were asked to write for the Scoliosis Research Society on, is this an actual okay thing now with all the technology that we have to put these instruments in the correct place? You might even ask me, was this screw put in by a robot or by a human being without a robot? And the question really is, we're going to be stuck with this. I just got a text from my buddy Eric Kleinberg about what cost conundrum. There's an arms race, a huge arms race in our field around enabling technology. And I've done my best to keep up with it as the years go on. But it's quite fascinating when you see the amount of things that we have now available. So this can be traditional navigation, it can be robotics, it can be 3D printed guides, which I'm going to talk a little bit about in this talk. There's really no one size fits all solution, and I'm going to talk to you about how to not be a fool. So for a lot of the fellows on the call, our current fellow, I think, is also on the call. I see him here. Some of you guys, I recognize your names. We've interviewed you for fellowship, so you're either done recently or starting practice. This is something where you've got to think about the economic situations that our hospitals are in currently, very, very constrained all around the country. We've also got radiation considerations to talk about. So the first thing to do is really to go to this NAS survey, which was done just a couple years ago, and this was really looking at what are people actually doing, and fluoro remains, the number one technique to help freehand surgeons confirm what they're doing. And then I think the second would be EMG testing of screws, which we all do. When you ask people, why don't you use your best navigation or your best robot at your place, they'll tell you all of the things that we know: limited availability, cost effectiveness, it takes too much time, right? And all of these situations become more and more and more difficult as time goes on. There's also this whole idea of utilization of navigation versus acceptance of navigation. There's always going to be a lag, right? There's going to be a friction in adoption of any new technology because of what we discussed as the cost, the time, the complexity, and other ideas like radiation. Radiation considerations are huge in spinal deformity surgery and really spinal fusion surgery. Because of that fluoro machine, right? We know that physicians can exceed their lifetime occupational radiation limit within the first decade of their career. We know that female orthopedic surgeons have a higher prevalence of breast cancer, et cetera. And for those of you MIS freaks out there, this is much, much worse. And so, if you're going to spend your life doing percutaneous instrumentation and MIS lifts, good luck. So, points to consider when evaluating these navigation solutions are quite significant. There's a long list of some of the literature that I reviewed for this talk, and it's quite significant, right? And really, the key things that I want you to think about are equipment that breaks. I'm going to give you a case of that. Obsolescence. You get your hospital to buy $1 million piece of equipment and then nobody uses it. That makes you look bad when you're going to your service line administrators or going to your operating room leaders and saying, I need this, and then you don't use it. And then what does it do for workflow? For me, enabling means it enables you to do your job better, not takes 3 hours longer. This is for Jesse Shen, who's also on this call. I think this is actually a really brilliant study done by our colleagues north of the border. This was, I think, centered really in Vancouver, and John Street, who's a senior author, is a close friend of mine from just up the street here in Seattle. And basically, they looked at how many reoperations do you need? What's the number needed to treat to justify bringing in cone beam CT-based navigation? So that would essentially be an O-arm and a stealth station in our situation in Seattle. And it's quite significant. You need 13 reoperations to actually justify this from a cost saving perspective. If you're having approximately 254 greater spine cases a year, which most of the centers represented in this fellows conference are doing much more than that. So something to think about. There's no one size fits all solution. The economics of your organization has to be discussed. Radiation that we're exposing our folks to is not insignificant. Now, something that I became interested in many years ago was this whole idea of patient-specific navigation. And I think that these couple of slides are just meant to show you that this story is not done yet. There are going to be a lot of patient-specific areas to think about. One of the tenets of a management method that we've used at our organization is basically called just in time, where you produce just what is needed at the time that it's needed with the minimum amount of people. The reason I started using these 3D printed guides is I had a difficult time back 2015, 2016 timeframe convincing anybody at our organization to either get a robot or get traditional stealth navigation. We have the stealth navigation now for just a couple of years, but at that time nobody was interested. And I said, we need help for these complex cases. And that's where I started using these. These are single-use, 3D printed, patient-specific mechanical guidance with a plan that comes pre-planned. Here's the process: you order the CT scan, you plan the case, the production of these 3D printed guides happens, the operation happens. And this is the first study that was done in the world that I led, that was presented at the SRS, was 83 patients, 27 surgeons, and 6 American sites, 3D printed guides, all made by the same manufacturer. Patients aged ranged from age 5 to 83. About 70% of the cases were pediatric cases, over 1,000 levels fused. And you can see here are the list of diagnoses that we use this for. And many of these diagnoses are diagnoses that you would use navigation for or a robot for nowadays. This is a lean NASCAR team kind of. I'm not really that into NASCAR, but I like using the NASCAR, strategy here. NASCAR is quite interesting, actually, honey. You should check it out. The plan is displayed. There's no lead. You instrument bilaterally at the same time. Both surgeons are doing the surgery at the same time. I have some sayings that I use while both surgeons are putting their screws in, just to make it light. The scrub tech's ahead of the surgeons, and it's just a fast environment. Here's a standard case. This case is from a couple of years ago, 2017. Patient with no landmarks, post-Harrington deformity. We planned for a 30-degree ALIF at L4, L5 instead of a PSO. You can see here there are no landmarks for pedicle screw instrumentation. So this is a case where you might want to consider using some sort of assistive technology in the operating room. This is a case where it is very hard to put pedicle screws in freehand. So that's what we did. And here are the 3-year post-op films. So in 83 patients, in 27 done by 27 surgeons, we found that this was a very safe treatment algorithm. Now, the question is how do you avoid becoming a fool with a tool? And this is really directed at you young surgeons who are going to go out into practice, who are thinking about these things. I will tell you, here are Sethi rules. If you can't do the surgery without navigation, you shouldn't be doing it. Let's just stop there and digest that. Freehand pedicle screw technique is the gold standard of open pedicle screw placement. Beruz is on the call. He's one of our senior mentors. I'll ask him to comment about that maybe during the question and answer. I'd maybe ask some of the other senior faculty like Dr. Kleinberg to question me on that. The robotics and navigation today are very early iterations of what we're going to see as the future goes on. I've shown you 3D printed guides. I think that's also just one iteration of what's going to come in the future. The technology that adds to your operations, that adds hours to your operations, is not enabling, it's disabling. So these are just some key things to remember as you go forward. I'm going to show you a quick case before we go to the question and answer section. This is a case that was just recently done at Virginia Mason, a very difficult and complex case where I felt I needed navigation. I felt I could do the case without it, but I thought the navigation was going to help us. And I really want to thank Jesse Shen, who's a current spine fellow at Virginia Mason, for helping me put these together just in the last couple of days. This is a 53-year-old man referred from Anchorage for an L4 paraspinal mass. This is a chondroid lesion. The radiographic imaging is consistent with a primary spinal tumor, most likely a chondrosarcoma. So we know from our data and from our studies that this needs an en-bloc resection. You can't touch this thing. You have to get it out without any disruption of margins. And so that was where the planning went on. This was a stage surgery with multiple team members representing orthopedic oncology, spine, plastics, for an en-bloc resection from L3 to S1, and then a extensive fusion from L2 to the pelvis with interbodies at every level, because much of the posterior spine has been resected and there's no fusion bed. I plan my osteotomies with navigation. And here is, a kind of replica of what those osteotomies were going to look like. We were osteotomizing the right-sided L3, 4, and 5 pedicles from within the canal. And my plan was to use the nav unit to show how deep we were in the pedicle with that osteotome. Guess what? The navigation unit froze during the osteotomy portion of the case. And the funny part was, you know how when United Airlines cancels your flight and you're on the phone with United and they tell you you're going to have to wait for an hour because they've rerouted your call to Manila and nobody's answering. That's what was happening to our rep. He was on hold while JC Levesque and I were in the most complex portion of this case, trying to get these osteotomes in the correct location. So the issue is you cannot rely on this stuff. It's not at a point yet where it is reliable, in my opinion. Here's we did get the specimen out on block. As you can see here, here's a radiographic image of the specimen. And you can see on the bottom edge here are the cuts of the pedicles that we performed from within the canal. Here's the path on the specimen cut and stained, showing you that we obtained an en bloc resection with excellent margins around. Here's the reconstruction. This man has other stories that I'll tell you about at another time. But the issue here is that we got this out on block, and that's the key thing. Here's the pathology report. So learnings in the last 3 minutes before I turn this over to question and answer. You must be able to do these spinal operations, and whether they're simple or complex, without navigation or robotics or 3D printed guides or whatever you're asking for. Augmented reality is one that we're starting to think about now, etc. Right? When this stuff breaks, and it will break, or when someone else is using it, or when there's a not as much of an issue getting it, fine, right? But the issue is that this is not as dialed in as we think it is, right? Safety is in the hands of you, the spinal surgeon, not some industry rep who has no contact with the patient. I know we all know that, but maybe that just needs to be said. These patients are coming to you, their families are coming to you to help them in sometimes very difficult scenarios. And the compact of safety really lies with you. It does not lie with the rep who's in the room and really has no connection or contact with the patient. So really, again, going back to that original principle slide, the 2 or 3 points that Hani wanted me to make sure that you understand. One is there is no one-size-fits-all solution. And I think that as I showed you, there's an arms race in robotics and navigation, and this arms race will only continue. Every company out there is spending millions and millions of dollars in their own version of what they think is enabling technology. The technology has to be enabling and not disabling. The economics of our organizations and the post, COVID era, and we're not even there yet. We're still inside the COVID era. The economics of our organizations have been hit really, really hard. And I've spent a lot of time in my career talking about how surgeons need to understand the forces of health economics. We need to really understand that $1 million machine may not come for another year. And how are we going to continue to grow safety and value and do complex cases despite that? Really, safety in spine surgery will involve this technology and navigation. It's here to stay. Okay, I'm not here to tell you that this is crazy and nobody's going to use it. I myself use 3D printed guides. I myself use stealth-based arm navigation now. And I didn't do that for many years. So I am adopting these things into my practice as well. But there's going to be further iterations of this going forward. So I think it's going to be really important for us to understand where this is going to go, for us to keep up. This is a reason to go to the SRS or go to IMAST or go to the AANS or go to the AAOS and continue to look at these technologies and adopt them as they improve. Thank you very much. I want to thank, just before I start the question and answer, all of my colleagues in San Diego. Bob, I see Bob there, Greg, Hani, Behruz, you guys are wonderful, and really thank you for putting this on.
Thanks for doing it, Raj.
Yeah, and thanks for all of our fellows who benefit from being able to hear from you in a time where it's not easy to travel with everything that's going on. If I could kick it off, Dr. Sethi, this is a topic that means a lot to me. And you mentioned that we are very much in the early sort of iterations of our development of robotics and navigation in the spine space. I guess one frustration of mine, you mentioned the arms race and every company is investing in robotics and navigation and enabling technology, et cetera. It just seems like an arms race to put in pedicle screws. And you brought up a couple examples where that is actually a significant challenge, like a revision or an oncology case. But for a lot of the degen cases, I feel like, pedicle screw instrumentation is not the part of the case that keeps most of us up at night. It's the more difficult part of the surgery, like an osteotomy cut or the decompression. And so I think one thing that's difficult, and if you have a comment on it, it would be great. One thing that's difficult is to try to, give companies the economic runway to make iterative improvements, like, pedicle screw insertion, but also to try to inspire them to do more with robots than just put in pedicle screws, which you should be able to do without a robot, to try to do some of the more difficult work in robotics. So I think that's what I'm hoping for the next generation.
Yeah, Henny, I think you've made a very key point. The pedicle screw placement, particularly in spine deformity oncology cases, is the easiest part of the case.
Right.
That's usually should be the most simple part. It's the in the case of the chondrosarcoma I showed you, it's the planning of the osteotomy cuts that's the more complex one. Or in a spinal deformity, same issue. These technologies are, I totally agree, at a very baseline level. Right now, it's the spinal robot. For all of you that's seen it, I've seen it, a couple times. Last time it was around, I decided not to because I'm like, what's the point? Right. It helps you put a screw into a pedicle, right? That's what most of these things do. Now, imagine the next generation that allow us, for example, in the situation of augmented reality, that let us do the surgery with our fellows before we actually do the operating, before we go to the operating room. We do the operation, wearing via, AR glasses in our office, for example, prior to the surgery. There's going to be an amazing trajectory of where these things are going in the next 5 to 10 years. But it has to be, I totally agree with you, more than just a pedicle screw placement device.
Yeah.
Raj, I'll ask you a question about how you see the future of managing the health system and hospital obstruction to these sort of technologies and how you're dealing with it at Virginia Mason. It is a challenge on a health economic level. So,
yeah, Bob, I think that there's no doubt, as we talked about here, is that the hole in our boats from the last couple of months is quite significant. We had a governor mandated shutdown again here in Washington State in January, part of February, which was really hard to understand, but that's what happened. And so now we're even farther behind on investments in research and technology, really, right? And so we have to continue as leaders at all of our centers to advocate for this stuff and to tell our administrators how important it is if we're going to maintain, ourselves as marquee centers, if we're going to train the next generation, if we're going to continue to take our field forward. These things are necessary. And as we talked about with Hani, I know that some of these technologies are only in their first generation, but we want to be involved in taking them to the second and third generation because they need our input. That's the other thing. Just like, somebody makes a new osteotome or somebody makes a new gear shift or somebody makes a new case, they need the surgeon involved in the iteration process. So I think we have to be involved in that. I think, Bob, the key thing is I think our surgical colleagues, and I know I gave you a lecture on this when I came down for that visiting professorship down there. We haven't done a good job at understanding the forces of health economics as surgeons, right? And we just think, well, we should just go ask for it because it's due. If we understood, some of the principles of health economics and some of the forces and how we would slot certain technologies into like a budget process, I think that could help us maybe connect more with the people that are approving these things, so that it's not always a no answer.
Yeah.
Good thoughts.
Yeah, we definitely fight that no answer. I mean, it's incessant, you know. We finally gained some traction here at Scripps, but I know many on this call too will matriculate from their fellowship years and then go out into practice and be challenged with that. Any of the fellows have any comments regarding your training and the use of navigation?
Yeah. Hi, Dr. Sethi. My name's Cody. I'm one of the San Diego fellows.
Hi, Cody.
Do you think that we're ever going to be obligated to use navigation? Because I know a lot of hospitals or hospital systems now have navigation policies or things like that, and a lot of people are training on it. As it becomes more widely available, do you think it's going to be, standard of care?
So I'm sad to say that the answer to that is yes. And I know that I don't know if Kleinberg's still on the call, but he can vigorously debate me on this as we debated this nationally. I have been asked in several legal proceedings to be an expert witness on cases where pedicle screws were malplaced and there was a O-arm in the hospital that was not used. Okay, I'm sad to see that because there is not really good evidence, right, that an O-arm actually is going to help you not put the screw in the wrong place. I think if you were to confirm that a freehand screw was out and you were to take that screw out, we do that all the time, right? We just don't like the way it looks and we take it out. That's probably more realistic. But yes, if you have an O-arm that lives in your hospital and you leave a screw in an aberrant location and it causes problems for the patient, I do think that's cause for worry now more than ever. Is it standard of care? I can't say that. I can't say that navigation or having an O-arm is standard of care. I'd ask some of the senior guys on the call to question me on that or debate me on that, but I can't say it's standard of care.
Rajiv, you mentioned for a comment, but I just wanted to bring up and emphasize the last slide that Dr. Sethi showed really is something that you need to keep in mind. And I think the fact that you have to be able to do the procedure without navigation, without anything, in case things happen, it's like having a open anterior versus minimally invasive. You need to know the basics. You have to really use that. I think the fact that you are the captain of the ship and people who help you, like reps and so on. I used to, in early 80s, I used to not allow the reps to come to the operating room, just to stay outside of the room. But I felt over the years that it is a teamwork and we have to use the knowledge and the help of some, but you are in charge. I think that those are the great comments that Rajiv made. And don't forget, the art of surgery still is important. And we have to use that experience whenever we use any advanced technology. So thank you for bringing those up. Those are all, comes to my heart. Thank you.
Thank you, Bruce. Yeah, I just in closing, I know that that we have a hard stop at 7 a.m., which is a minute away. I will tell you that I can't speak more eloquently than Behruz on the topic of the fact that surgery is an art. These patients come to you; they do not come to see a robot. They do not come to see a stealth machine, and really spend time as a fellow learning the anatomy. And I think that will always be your true north in situations where you may not have these tools. You may not have the ability to really take some of the newest class devices. As Greg Mundis said, answers often no before it's yes. But if you go back to that true north of anatomy, and even if you're doing the case perk and you're looking at a fluoro machine, there's basic principles that we always have to keep in mind going forward. The other part of this is I want to make sure you leave with the thought that this is in our future for sure. Robotics, navigation, assistive technologies, enabling technologies are here to stay. They're going to look very different in the next 5 to 10 years, and they're going to be better.
Well, thank you so much, Dr. Sethi, and for getting us in right on time. Great talk, and something that's so relevant to our fellows. I just want to put in one last plug for the research grant. Please reach out to us if you have a research project that requires some support, and we'll be happy to review your application and look forward to the next session. So thanks again, Dr. Sethi, and everybody have a great day.